On behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank everyone for tuning in today for the MSK case presentation series. My name is Aline Serfari, and I'm here today with Dr. Hilary Humans and Dr. Behrang Amini, who coordinate this series with me, and our guest speakers, Dr. Flavia Costa and Dr. Guinel Hernandez. In addition to his collaboration in running the series, Dr. Amini will also be sharing 2 cases with us today. Before we begin, I want to let you know that the presentations today, like all the previous ones, will be recorded and will be available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you haven't registered yet on the new OCAD website, please consider doing it, and you'll be able to check out all the lectures and cases in the archive. I also want to bring to your attention that next week, Dr. Liz Metzkin from Brigham and Women's Hospital will give a lecture on sex-based differences in common sports injuries on April 1st, 8 a.m. ET. Now back to our presentations. The speakers today will present their cases, and at the end, they will respond to any questions you might have during their presentations. If you have any questions at any time during the presentations, please put them in the chat box, and they will respond to them. Attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, or sale of this material is illegal. We thank you so much for your understanding, and without further ado, I will ask Hilary to introduce our first speaker today.
Good morning, good afternoon. I have the pleasure of introducing my OCAD virtual colleague, Dr. Amini, who's an associate professor in the Division of Diagnostic Imaging at MD Anderson Cancer Center. He's the program director of the Musculoskeletal Imaging Fellowship Program and MR Medical Director for the division. He specializes in oncologic musculoskeletal imaging, which includes diagnosis and follow-up of bone and soft tissue sarcomas, bone metastasis, and hematologic malignancies affecting the bone marrow. His background in electrical and computer engineering has allowed him to make valuable contributions to divisional informational technology projects and to harness available IT resources for collaborative educational and research projects.
Thank you very much, Hilary. Thank you for the invitation to present. I've been a long-time listener, first-time presenter. So today I'm going to present 2 cases. The first case is going to be a bone case, and the second is soft tissue. There we go. So this is the first case, a 59-year-old man with newly diagnosed oropharyngeal carcinoma, and I'll pretend I'm a neuroradiologist and I can tell there's a tumor right here in the base of the tongue, floor of the mouth. The patient had a whole body PET CT performed as part of his workup. We do a dedicated head and neck PET CT zoomed in, and then the rest of the body here. And as you can tell from these images, there's a lot of stuff outside the head and neck in this patient. So there's a rib lesion, there's something going on in the pelvis, and then we'll take a closer look on axial images here. So on axial images through the chest, we see this area of increased uptake. The lungs look okay. When we put this on the fused images, we can see that there's this structure at the bifurcation, and that corresponds to an FDG avid lymph node. And then there's a little bit of increased uptake at the hyla as well, although that's not specific and something we see very commonly. When we look at the abdomen, we see that there's an increased FDG avid lymph node behind the inferior vena cava. And then we get to the MSK part of this, where we see this large FDG avid bone lesion. And if you look at the bone windows, there's really not much going on, no trabecular destruction that we can see on the CT images, but you do see this intensely FDG avid lesion. So this is very atypical first presentation for a head and neck cancer. nodal disease below the neck, bone metastases. So this patient got dedicated imaging to further work up the bone lesions. And as you can tell, there's this is a T1 weighted, T2 weighted coronal images over here, T1 weighted, T2 and post-contrast image axial on the right side of your screen. So you can see this well-defined lesion with maybe little dots of high T1 signal that suppress out on the fat-saturated images, and this lesion is intensely T2 bright and intense and avidly enhancing. So concern was raised for metastases given the appearance on the PET-CT, and additional imaging was performed. This one is of the lumbar spine. Again, the same sequence of images, T1, T2 fat-sat and post, and then T1 axial and T1 fat-sat post. And again, very similar appearance to that iliac lesion. This one has kind of these fuzzy brush borders with areas of increased T1 signal centrally, and in this case, mild enhancement. So this patient was diagnosed with stage 4 disease with distant nodal and skeletal metastases. He underwent chemotherapy. He only tolerated 4 cycles. And then he said, I don't need any more chemo, and he refused treatment. And then we didn't hear from him. He comes back 7 years later, and this is the PET-CT. And you can see there are multiple areas of increased uptake throughout the MIP that you can see there. And then we'll just revisit the image we had seen before. This is that acetabular lesion we had seen, and you can see that it's actually increased in extent. SUV had gone up, and there's a new lesion in the contralateral acetabulum as well. This was biopsied, and before I give you the results, any thoughts from the group? If you want to put it in the chat box, I'll monitor. If someone wants to tell me what they think this is. If not, I'll go on, and you can think about it. So I'll give you a differential diagnosis of bone lesions with increased T1 signal, and the increased T1 signal could be due to fat or just non-fat high T1 foci, and sometimes it can be very hard to tell these apart, especially with tiny metastases. I'll tell you, during my residency, my differential diagnosis for fat-containing bone lesions was basically hemangioma, red marrow rest, and the obvious lipoma, which I'm not putting in here because that's such an obvious thing. But as you kind of go along with your training and experience, you see that there's a lot more stuff that can include fat. And then a lot of malignancies also have these high T1 signal foci that can be very confusing and can lead you down a benign path, but you should always have these on the back of your mind. Again, these are rare presentations of and rare malignancies, and sometimes rare presentations of these malignancies. So the primary consideration when you see fat in a lesion is benign, but please always have these other differentials in your mind. So I'll go through some of these just for demonstration purposes. This is our old friend hemangioma. Everyone knows what these look like. T1 bright, they can have high T2 signal, and they can enhance. CT is the answer that gives you this nice spoke wheel appearance or corduroy appearance. Red marrow rest, this was a patient with childhood chronic anemia. We're not sure what type. It was worked up outside, but the patient came in with suspicion for metastatic disease. And you can see that this patient has a lot of dots in the marrow, this fat-containing lesion over here, mildly T2 bright, and virtually no enhancement. And move this out of the way so I can look at all the images. Okay, and the key here was that there's no FDG avidity, very subtle lesion, maybe a little bit of increased attenuation or enhancement on the CT image. Another differential consideration is something we don't really think too much about in the spine, which is a benign notochordal cell tumor. These are the benign cousins of chordomas. Some people think they're the kind of younger versions of chordomas. Ill-defined margins. The key is that, like chordomas, these are very T2 bright, and unlike chordomas, they do not enhance. Something to consider. When we see these in the sacrum or clivus, it's a little bit easier, but they can happen in the spine. Bone infarctions. This is a patient with treated leukemia and areas of bone infarct, and you can see this very nice signal abnormality at the watershed zones of the the cervical and thoracic vertebrae. And in the acute phase, these areas of infarction can be FDG avid and can confuse people. And you can see that there's areas of fat within these infarcts, just like you see in the long bones. This is a patient with treated lymphoma, initial lesion here, intensely FDG avid. And after systemic, I think this patient actually had radiation therapy as well. You can see this very nice infarct with areas of fat inside. A lot of tumors can basically disappear into the background marrow. This is a very good response in a patient with prostate cancer. You can see this lesion over here. And if you closely look at this, you can maybe see areas of high T1 signal. We'll get to that later. But after therapy, this basically turns into marrow fat with maybe a subtle rim of signal abnormality remaining. And there's a little incidental red marrow arrest right next to it. This is a patient with sarcoid who initially came to the lymphoma myeloma clinic, and you can see these fat-containing lesions, typical distribution pattern of lymph nodes in the mediastinum and hyla. This patient also had innumerable liver lesions and bone lesions as well. The key here was these high T1 signal areas or fat inside these lesions. This is another rare entity, Hypernoma. Actually, this one was interesting because the patient came to the myeloma clinic and the person reading the PET-CT put everything together as myeloma with extramedullary disease. Luckily, they biopsied one of the liver lesions and got the correct diagnosis for the patient. This one is a hypernoma. You can see very small areas of fat, very intense T2 signal, and very intense enhancement. And again, a very rare entity, hypernoma. These can be very FDG avid, especially just like brown fat has FDG avidity. Again, very rare entity. This is a patient with papillary thyroid carcinoma, and you have this metastasis over here. It has these high T1 areas, avid enhancement, restricted diffusion, and intense uptake on PET. This is a patient with adenoid cystic carcinoma. This is one of the malignancies whose bone metastases intrinsically have these high T1 signals, and they can be very confusing, especially when solitary. You'd easily dismiss this as a hemangioma, especially you can imagine the spoke wheel pattern on the T2 weighted and the post-contrast images, not much enhancement, but fortunately PET was done and it was FDG avid. Adenoid cystic carcinoma is one of those lesions that doesn't have a lot of increased uptake on PET. For the bone mets, luckily in this case, it did have a little bit of uptake, which helped us with this. All right, let's get back to our case now. So we've had that huge differential. This is the 59-year-old man, newly diagnosed oropharyngeal cancer, nodes below the neck, and these lesions with areas of increased T1 signal that look like they're dropping out, so we're attributing it to fat. So I'm going to go back to the chat box and see if there's any comments on differential for this. Okay, we have one vote for histiocytosis. That's actually, you're talking about something like LCH possible. So this patient had a biopsy and came back sarcoid. So this is a very tricky thing. We run into this a lot. It's not just sarcoid is in the primary manifestation, but also sarcoid-like reaction in response to just chemotherapy or immunotherapy. A lot of times patients don't have sarcoid beginning of their treatment cycles. When they come in after the first or second cycle of therapy, we see these bone lesions. Again, very uncommon, but something to keep your mind on. And that's actually a sarcoid-like reaction in response to the systemic therapy. So the question is, can sarcoidosis and METs be reliably differentiated on routine MRI? And the presence of intralesional fat can help. This brush border that they described, this kind of fuzzy margins around the lesions, can help tell you sarcoid versus metastasis. But, and this was very similar to our case with these fuzzy margins. But in the end, they conclude that they cannot differentiate sarcoid from bone metastases with any reliability. So it's something to always keep in the back of your mind. It's a very uncommon presentation. Some things that could help you if you have symmetric adenopathy and a distribution unusual for the primary malignancy, you should consider that. But always remember, skeletal sarcoid is rare, and presence of fat in an untreated bone lesion is usually reassuring. But as we just saw, a variety of benign and malignant lesions can have this appearance, and differentiation can be difficult. That is it.
Thank you very much, Behrang, for your presentation. Now I'm going to go to the second presentation today. We have the pleasure of having Dr. Flavia Costa join us today. She's an adjunct professor of musculoskeletal radiology at the Federal University of Rio de Janeiro, where she also graduated. She completed the residency at Pedro Ernesto Hospital at the State University of Rio de Janeiro. She's also the section head of MSK Imaging at Clínica de Diagnóstico por Imagem, DASA. She's interested in all areas of MSK imaging with emphasis in oncology. She frequently presents in national radiology conferences and has authored several peer-reviewed scientific articles. We are delighted to have her here today, and with that, I will turn it over to her. Please, Flavia, share your screen.
Okay, hi everybody. It's okay. So I'd like to thank Alini and other organizers for the opportunity to participate in this section. And I'm going to present the second case. So it's a 43-year-old male prison guard presented with right knee pain for 3 months, following prolonged standing at work, no previous surgery or disease. So X-ray on AP and lateral incidence. Here it's difficult to see, but there is a hyperlucent image in the subchondral area of epiphysis with sclerotic margin. It's just a little hard to see, but it's a benign appearance. And here on CT, on coronal plane, you can see a lytic lesion with sclerotic margin, and it's like a sclerotic reaction around the lesion and several calcification inside the lesion. So on T1, the sagittal plane, you can see subchondral area with edema around the tumor. The subchondral area here, the cartilage, it's undamaged, just a few joint effusion and edema surround the lesion. And here in axial T1 fat suppression, the lesion hyperintensity on T1 fat suppression. So you can consider the high protein content, blood, or melanin. So on DP fat set, you can see in sagittal plane here the lesion, the subchondral area. Here the cartilage is undamaged, and a parietal thickening inside the lesion. It's too much edema around the lesion. And here the parietal thickening with irregular margins. And here periosteal reaction and too much edema surrounding and just a little joint effusion. So, and SWY, the susceptibility artifacts inside the lesion, you can see the calcification, but also could be the blood or melanin inside. On DWI, you can see here the hyperintensity in parietal thickening of the lesion. And here hypointensity on ADC map, suggestive of hypercellular tissue. And here around the lesion, the edema with hyperintensity on DWI and hyperintensity on ADC map also. So it's suggestive of edema. On the perfusion color map, you can see here in red, in the parietal thickening, the time intensity curve type 4, and washout phenomenon here, which means hypervascularization or tumoral neovascularization. And here inside the lesion, a necrotic part of the lesion or even cyst component. And around the tumor in yellow and green, edema. And here the artery, the same time intensity curve of the tumor. So in T1, post-contrast in fat set, you can see here the parietal thickening with necrotic part of the tumor or cyst component. Tumor edema after enhancement. Here the irregular margin of the lesion and the periosteal reaction. So it's a very small lesion with locally aggressive features on MRI with too much edema. So I thought in 5 many different diagnoses, considering all of this. And considering chondroblastoma, this patient is out of the age range of the disease. In clear cell chondrosarcoma, this tumor usually has no periosteal reaction and has low incidence of calcified matrix inside. And in chondromyxoid fibroma, this tumor usually affects metaphysis of long bones and has usually no periosteal reaction. The giant cell tumor usually has no sclerotic margin and no calcification inside the lesion. And metastasis is more common in the spine, pelvis, and ribs, but appendicular skeletal metastases are very uncommon. And I'd like to consider melanoma because of the high hyperintensity on T1 fat suppression. So on microscopic examination, we can see undifferentiated epithelioid neoplasm with malignant features. On immunostudy, you can see markers, these markers here, and the findings are indicative of malignant epithelioid neoplasms with melanocytic differentiation. So the diagnosis, metastasis of melanoma. This patient had a surgery of a superficial cutaneous lesion 5 years previously, but neither him and his doctor checked the result. So unfortunately, this is very common here in Brazil. So no follow-up was done to this patient. On the PET-CT, you can see brain metastasis. It was done 3 months after the MRI. So lung metastasis here on coronal plane. And axial plane, you can see brain metastasis, several lung metastases, and just 1 bone metastasis to distal right femur. So malignant melanoma metastasis, solitary or to skeletal muscle or bone, occurring 0.8% of patients, and osteolytic lesion with medullary orange, it's more common. In spine, pelvis, or even ribs, sorry. So MRI is a good method using anatomic images and also advanced MRI images to evaluate the tissue extension and may demonstrate evidence of aggressive features in the presence of melanin. So it's, sorry. It's okay.
Okay, thank you, Flavia. Now, Behrang, we go back to you. Your second presentation, please.
All right, thanks again. This one will be a shorter presentation, I hope. So this is a patient that presented with 1 year of wrist pain and then more recently felt a painful bump on his volar forearm. And we have T1, T2, and post-contrast images right here. On T1 images, we can see this infiltrative high to intermediate T1 signal process in the fascial planes. T2, it's intensely bright, and on post-contrast, it has this heterogeneous but intense enhancement, and this spreads up and down the forearm, and this we believe was the bump that the patient was feeling right here. So the differential diagnosis for this kind of fascial enhancement is some kind of fasciitis, either infectious, eosinophilic, autoimmune. Desmoid fibromatosis can have this kind of infiltrative feather-like pattern of spread. And then we've also seen these fascial tails with myxoid sarcomas. So this patient was biopsied and came back myxoid sarcoma. This is a myxofibrosarcoma specifically. The new WHO classification puts it in the spectrum of malignant fibroblastic neoplasm. These tumors can have variable myxoid stroma. Used to be called myxoid MFH. So MFH has fallen out of favor in favor of UPS, unclassified, undifferentiated pleomorphic sarcoma. And then myxoid MFH is now just called myxofibrosarcoma. But be aware of those older terms. Myxofibrosarcomas are slowly enlarging and painless masses. One of the most common sarcomas of the elderly, usually present in the 6 to 8 decades of life, as in our patient, and there's a slight male predominance. These typically involve the limbs, including the shoulder and hip girdles. It's usually in the lower extremity, followed by upper extremity, and then very rare locations include the trunk and abdominal cavity. And more than 50% of these actually are dermal and subcutaneous tissues. So a lot of times these don't make it to imaging and are handled by dermatologists and unfortunately sometimes by general practitioners who take them out in the office with positive margins. On pathology, these have variable cellularity, pleomorphism, and proliferative activity. They range from low grade to high grade. The grade is inversely related to the percent that is myxoid. On pathology, as on imaging, they have this multinodular growth, myxoid stroma, and these infiltrative margins. So even in the hands of experienced surgeons, getting clear margins on these tumors can be very difficult. Prognosis in these patients, unfortunately, the patients have local and repeated recurrences in 30 to 40% of cases. The recurrence pattern is actually unrelated to the grade and probably has more to do with this infiltrative pattern. And there's a relationship to inadequate surgery, but even in, like I said, with good surgery, it's hard to get clear margins on these sometimes. The low-grade lesions have no metastases. The high-grade lesions have metastases in up to 35% of cases, and the intermediate grade are in between. And the metastatic grade is actually lower compared to other high-grade pleomorphic sarcomas. So that's, I guess, a positive aspect of these tumors. And then the epithelioid subtype has increased risk for metastases. There is a 5-year mortality of up to 35%, and it's related to local recurrence within the first year, size, grade, and surgical margins. The imaging of these tumors is very interesting. On T1, they can be intermediate to low. On T2, the non-myxoid components are intermediate to high, and the myxoid components are very fluid rich, so they are very bright. The post-contrast appearance is also related to the component. The non-myxoid components typically enhance. The myxoid components don't typically enhance on early phase images, but have this feathery delayed enhancement, which is reflected in the dynamic contrast enhanced studies that show this slow wash-in. And the myxoid components, as expected, don't have any restricted diffusion. So this is a case where DWI can actually lead you to the incorrect conclusion. These are some other examples to kind of demonstrate the range of these tumors. This is T1, T2, and T1 fat set post with the axial and coronal images. On T2, you can see this component over here that's somewhat bright and has this kind of feathery enhancement. And then there's all this infiltrative enhancement and high T2 signal in the adjacent soft tissues. This is a cut taken further up, and you can just see mostly just this enhancement, linear, fascial tails, everything. That looks more like inflammation than a tumor. This is another patient that demonstrates the more myxoid appearance of these tumors, very T2 bright, multilobulated, and intermediate to low on T1. And on FATSAT, T1 post-FATSAT, you can see this kind of peripheral enhancement that if we did DCE, it would slowly fill in a feathery pattern. And I want to spend a little bit of time talking about this fascial tail. Different people have looked at the presence of a fascial tail to be able to tell if the patients, if we can make a prospective diagnosis of myxofibrosarcoma, and it's been variably successful depending on the study. You have sensitivities ranging from 60 to 80% and specificity 80 to 90%. So just be aware that when you see this, it's not specific for myxofibrosarcoma. A lot of myxoid sarcomas can do this. Even myxomas can do this. But if it's an aggressive looking lesion and you see this, you can put myxofibrosarcoma in the differential. The part of these tumors that's actually very painful for us is the recurrence pattern of these. So this is a normal soft tissue sarcoma. This is the pre-op imaging. These are the post-op imaging. And then this is when the tumor recurs. It recurs as a nodule, and nodule is its tumor, and you call it. And this is a bored cat reading one of these studies. It's not very interesting. Myxofibrosarcomas, in addition to being interesting at presentation, here you have this linear pattern of this tumor. This ended up being a subcutaneous myxofibrosarcoma. It was taken out, reconstructed with a flap, and there's the flap right there showing some flap edema after surgery. We followed this patient every 3 months for a year, and then the patient came back. And you see a little bit of fullness in this flap and maybe a little bit of enhancement in this area over here. This was obviously not called recurrence. Maybe it was some kind of flap complication or edema. And then on the next follow-up, it actually presented itself as a recurrent myxofibrosarcoma. In retrospect, that was the area. And these are the tumors where I get up and grab a cup of coffee before starting to read these for the recurrence, because they can be very scary for me. And these are some other examples of myxofibroma recurrences. This is one right here. This is another one right here. And this is another one right here. And each of these, the key was looking at the immediate prior scan and seeing that this either was smaller or was not present. But on a single time point, when you look at this, you can easily dismiss it as a vessel or just some inflammation from surgery or radiation. So we did a little study to see if we could predict whether the recurrence pattern was going to be related to the initial presentation. So if the initial presentation was kind of this linear infiltrative pattern, would the recurrence be the same? And there's some suggestion that if it's infiltrative or mixed appearance at baseline, and mixed meant that there was a solid component with these tails, that the recurrence was infiltrative or mixed. But our general conclusion at the end of this was that there was really no pattern, and you should always be on alert for linear enhancement pattern indicating recurrence when you see these patients on follow-up. That's it.
Thank you, Behrang. I have to admit that I'm afraid of missing it. The cases you just showed, like so small lesions.
Yeah, they're scary.
Yeah, actually going to get a coffee before reading it is actually important. So we can make
and if you have anything stronger, that's better.
Yeah. Okay, next guest today. Dr. Guinel Hernandez Filho is a practicing musculoskeletal radiologist at Teleimagem HCor and Alta DASA in São Paulo. He completed his residency, his MSK fellowship, as well as his master's degree at Santa Casa de São Paulo Hospital. He did his MSK research fellowship at the University of California, San Diego. He's very involved in MSK radiology education, having presented at Radiologia national conferences. Please, Guinel, share your screen.
Hi, good morning, good afternoon for everyone. Apologize for my Brazilian English, but I will show you an interesting case that we saw at our institution last year. And there are a lot of interesting teaching points in this case. So it's a 21 years old male. He's following congenital disease at our institution since 2012. This X-ray from 2013, we see low bone density, and we saw also deformity with bowing of diaphysis of the radius and ulna, and we see like a calcification near the interosseous membrane also. 7 years after, we see other X-rays from this patient, that we see a thoracic spine X-ray, a right thoracic scoliosis with reducing of the height of the vertebral bodies, showing multiple fractures of the vertebral plateaus, and also low bone density, we can see here. This pelvis X-ray, we see also this low bone density and protrusion acetabula bilateral, and also the thickening and pattern of bone marrow. We also see that these patients suffered different fractures at different times. So we see one fracture at the proximal ulna treated surgically, and another fracture at the distal diaphysis of the contralateral forearm. This patient came with new symptoms, 2 weeks presenting rapidly enlarging swelling of the proximal right thigh with no inflammatory signs and no trauma history. So at the X-ray from January, we see the soft tissue enlarging near proximal diaphysis with no fracture at the diaphysis or cortical abnormality. We performed also an MRI that we saw at the T1 images like hyper intense when you compare it to the muscle surrounding mass surrounding the proximal diaphysis of the femur, with apparent no involvement of the intramedullary bone. The stir sequence, we see a hyper signal of this mass surrounding the proximal diaphysis and this length with peripheral areas of linear low signal. Mainly at the proximal part. After injection of gadolinium, we saw a very important and homogeneous enhancement of this lesion and showing probably a high vascularity of its nature. After 1 month following the case, we see an enlargement of the soft tissue mass, but we also saw like a linear or peripheral calcification of this lesion. According to this congenital disorder and the history of multiple fractures, as we treat a lot of patients with this condition, the surgeons, the oncology surgeon, the referring physician, decided to follow up and no biopsy of this case. 1 month after, more than 2 months after the first X-ray, this is a CT showing the linear calcification on the periphery of the lesion, like we see in this coronal reconstruction. We have also a lamellar periosteal reaction in inner part of the diaphysis of the femur. We see here the containing is hyper intense, hyper attenuation within the lesion, and I will show you. And a follow-up. This image is first, and after 5 months follow-up, we see the changing of pattern of the attenuation of the lesion. I'll show you in this image. So here, the surrounding lesion have a hyperattenuation within the lesion, and we see 5 months after that this hyperattenuation changed to a hypoattenuation similar to fat tissue and similar to medullary bone. We should think that should be a myositis ossificans is a very similar type-like, but is a different condition. During this follow-up period, some other thing happened. In April, he had a fracture of forearm, radial and ulnar. And in June, 2 months after, he had a similar situation at near the fracture with a very intense and proliferative bone callus. So we have 2 different diagnoses here. We have one diagnostic of the congenital disorder and one diagnostic of the current abnormality. This is a case of osteogenesis imperfecta type 5 with hyperplastic callus. The osteogenesis imperfecta type 5 is a heritable disorder characterized by brittle bones. Classically, we have type 1 to 4 according to clinical phenotype. And for 1 to 4, we have this genes abnormality, which it does not happen at type 5. The type 5 is characterized radiologically by interosseous membrane calcification at the forearms and radial dense band visualized at the growth plate. These patients do not have a blue sclera and the tenogenesis imperfecta. And the clinical and radiologically most conspicuous feature of this type of osteogenesis is the hyperplastic callus. This hyperplastic callus is rapidly growth and have distinctive zones of callus containing either edematous tissues, collagenous tissues, and woven bone, as well as small cartilaginous island. The main differential diagnosis is osteosarcoma. And the majority of fractures in this type of osteogenesis not even heal with this type of callus. They heal normally. But hyperplastic callus always happen in osteogenesis type 5. And we can also find this type of callus in places where we don't have fracture, like our case. So I separated some highlights that can help us to do some diagnostics. So for the diagnosis of osteogenesis imperfecta, we have this interosseous membrane calcification, and also we have these dense bands at the growth plate. This case is not very classic, but there are some that we can see here. Other thing is that this low signal line is around the tumor may represent this cortical and calcifying of the periphery of the healing of the callus. And we also can see the edema surrounding or inflammatory tissue at the above this line that we can see also at the CT. This case, we can see also the hyper attenuation, this calcification of the periphery of the lesion. And you can see also the edema surrounding the lesion. We have this peripheral calcification. And I also noticed that this lamellated periosteal reaction is more common at the healing bone processes, different from the osteosarcoma, that we can find more linear and thin periosteal reaction. We see also that there is no intramedullary extension. This is an MRIT1 sequence of this case. And look at this osteosarcoma. This is a conventional osteosarcoma, where is the medullary involvement of the tumor. This case is very similar because it's a periosteal osteosarcoma. We see calcified tumor, and we see intramedullary extension, and see a very well-defined lesion within the bone. Other thing that is very interesting is the changing of the pattern of within the lesion, that of hyperattenuation, it turns to like fat content similar to bone marrow. And we also see the reduction of the edema surrounding the lesion. Summarizing, I would like to show you this congenital disorder that have typical radiologic findings, this association with hyperplastic callus, and this main differential diagnosis. This is my references. I'd like to thank everyone, and also I'd like to thank my colleagues that collaborated with me with this presentation.
Thank you very much, Guinel. Beautiful. It's a beautiful case. Let me see if there's any question. I don't see any questions. Do you have any questions? One from each other, like Behrang or Flavia or Guinel? Do you want to ask any questions?
No, those are beautiful cases. Thank you for sharing.
Okay.
I'd like to thank you also. No questions, thank you.
Okay, so thank you all for tuning in today. We look forward to the next session, which will be held in April, April, with a focus on sports imaging. Thank you all for sharing all these beautiful cases, and see you next time.
Run 10 seconds.